Hi, I'm Dr. George Martin. I'm a practicing medical dermatologist here on the island of Maui, and I moved here in 1989. But my entry into dermatology was back in 1985 when I was a first year derm resident at UCLA, and having just finished an internal medicine residency, I began to learn quite a bit about the patients who suffered from vitiligo. And the evolution over the last 40 plus years has been nothing but astounding for these patients who were really an orphan disease for decades. And so my initial experience with vitiligo, we understood it was an autoimmune disease with the destruction of melanocytes. And our first step was to turn off the inflammation, which we did with systemic steroids, topical steroids. We would use methotrexate, and we would attempt to halt the progression. And then over time, TCIs came available, the topical calcineurin inhibitors like tacrolimus, and we began substituting them in for vitiligo of limited areas. Obviously, systemically, if we gave steroids, we cover a broad area, but if it was smaller areas, we could cover them with topical steroids and then to the TCIs. And so fast forward, the entire field has changed with the advent of JAK inhibitors, which really target the inflammatory pathway in vitiligo. And that is to say that the JAK inhibitors target interferon gamma, which is the major cytokine that drives vitiligo and the destruction of melanocytes. And so, fast forward, we have the development of topical ruxolitinib, which was a total game changer and proof that the JAK-STAT pathway was a major pathway involved in the pathogenesis of vitiligo, and drugs like topical ruxolitinib and even systemic ruxolitinib used off-label were effective at turning off the inflammatory process in vitiligo and allowing melanocytes to repigment and the area. And so a couple practical pearls about treating vitiligo with topical therapy. So number one, you have to tell your patients and set expectation that areas that are completely devoid of any pigment, any follicular pigmentation, are going to take quite a bit of while for not only just for the inflammation to turn off, which happens pretty quickly, but for melanocytes to migrate in and fill up the depigmented area. If the patient is fortunate enough to have little islands or reservoirs of melanocytes that can migrate out, the hope is that the repigmentation will take place more rapidly. So that's setting expectation. The second thing in our attempt to turn off inflammation and get the area to repigment is you have to be patient. In the case of topical ruxolitinib, we know that repigmentation starts and continues over years. And so when patients ask me, like, how soon will this all repigment? I tell them it's a work in progress, and we'll know at about 6 months how well you're doing. But what we've seen is that people continue to repigment after 2 years on topical therapy and even into their third year. And so it's fantastic. And so our current recommendation for managing vitiligo, depending on if it's limited or diffuse, is the following. First, understand that vitiligo is a clinical diagnosis, and that Wood's lamp will help you identify those areas of depigmentation. It is true depigmentation, not hypopigmentation, but depigmentation. And a biopsy is rarely necessary. The other thing that you need to know in treating vitiligo is that you really have to ask the patient about any signs of sort of neurologic involvement, and these are signs and symptoms early in life of like VKH or other autoimmune diseases that involve the central nervous system. And most importantly, about 20% of patients with vitiligo will suffer from a concurrent autoimmune disease that can develop either anywhere along the pathway, including before or after development of vitiligo, the most common being thyroid disorders. And so I screen annually for thyroid disorders, as well as pernicious anemia and other autoimmune phenomena involving like B12 deficiency and pernicious anemia, and obviously hypothyroidism, among other things, and diabetes. You really want to make sure that your laboratory panel includes a fasting blood glucose or hemoglobin A1C. So moving forward, once ruxolitinib had been established as the go-to topical therapy, when a new patient presents to me with rapidly evolving vitiligo, and this could be something as simple as like cavernarization, where they develop vitiligo and trauma, or they get sort of a confetti depigmentation or trichrome vitiligo, my first go-to is a systemic steroid. And usually that's dexamethasone, 4 milligrams, 2 days a week, like a Saturday and a Sunday usually. And that helps turn off the inflammation from a systemic route. If you have access to narrowband UVB, which I don't have on Maui, narrowband UVB is really a quite effective tool, as are some of the lasers that are effective at repigmenting. And then, of course, our topical therapy, ruxolitinib. And excitingly, we have the advent of JAK inhibitors, systemic JAK inhibitors specifically. And there's some really good data coming out with, for example, upadacitinib, their phase 3 data, very, very strong data on repigmentation. So that use of systemic steroids up front, I could see intervention with a JAK inhibitor. Also coming to the forefront are other JAK inhibitors in this space, like ritlecitinib has some phase 2 data headed into phase 3. And then also important is that the systemic use of povorocitinib, which is a very potent JAK1 inhibitor developed by the company that also makes ruxolitinib, would be is in the works. So we're going to see an evolution of a JAK explosion, not just with the continued use of ruxolitinib, but we're going to see systemic JAKs that have a great safety profile, or appear to be highly efficacious, and really are evolving the field rapidly. And as an alert to everyone treating vitiligo out there, patients want to know, can I stop my therapy? And what you need to know is this, that patients stopping therapy, whether topical or systemic, half of them will redevelop their vitiligo and depigment within months of stopping. And this has been well established. So we're not quite certain who's going to depigment when you stop therapy. So the recommendation is that we continue therapy. Well, with that being said, why does depigmentation occur after cessation of therapy? It turns out that a major driver for vitiligo is the presence of tissue-resident memory T cells, right? And what these T cells do is that if you take a CD8 positive T cell involved in the destruction of melanocytes and in the influence and under the influence of IL-15, they turn into tissue-resident memory T cells that can last as long as 10 years in the skin and continue that inflammatory process that results in the destruction of melanocytes and the persistence of vitiligo. Well, in development is an IL-15 antibody directed against the IL-15 receptor. And so that hopefully will change the entire game plan and prevent the development of tissue-resident memory T cells and the persistence of vitiligo. So just know that our patients who suffer from severe vitiligo, that hopefully someday that antibody will come to the forefront and we'll be able to get rid of those pesky tissue-resident memory T cells that are driving vitiligo and keeping that process of depigmentation going. If we can remove them, there's a greater chance that those patients will repigment. So in the present, we have topical ruxolitinib on the doorstep, probably in 2027. We're going to have a systemic JAKs coming forward. Most likely upadacitinib will be the first to market, but followed very closely by povorocitinib and ritlecitinib. And they're going to be total game changers and hopefully avoid our need for systemic steroids. And then down the road is a IL-15 monoclonal antibody that will be the real game changer and hopefully change what is currently a chronic disease into a transient disease. And so with that, I've sort of given you my historical perspective over the last 40 years of treating many, many vitiligo patients. And in parts of the world where I teach about vitiligo, they actually think it's a contagious disease. So just as an alert, just remind patients who may not be as well educated as we'd hoped that this is not a contagious disease. It's an autoimmune disease. We have to screen them for other autoimmune disorders. But now we have hope, and we have great evidence with our topical and soon-to-be systemic therapies for the treatment of vitiligo. So I want to thank you for listening, and mahalo and ahui ho. Aloha.